Hello, my name is Dr. Glenn Brooks. I'm a board-certified plastic surgeon from Longmeadow, Massachusetts, and today I'm going to talk about breast augmentation, the surgery itself, some of the risks, how the surgery is done, and what you need to know if you're interested in having the surgery. Breast augmentation versus breast lift. Now, breast lift, where you tighten the skin envelope and bring the nipple and the whole breast higher on the chest, whereas breast augmentation is to increase volume. And we increase volume in patients who have lost volume either because of weight loss, pregnancy, or simple aging. So breast augmentation has been around for a long time. Actually, since the 70s, we've had silicone and saline breast implants. What happened over time was there's some questions about the safety of breast implants, especially silicone breast implants in the mid to late 80s. It took several years and many plastic surgery studies to show that silicone breast implants were safe. And they came back on the market actually in 2006. So here we are many years later with a great safety profile for silicone breast implants. For a period of time, saline were the most popular. Silicone are now the most popular, and about 95% of breast augmentations in the United States are now silicone. So that gives me great comfort in most of my patients getting silicone implants, and that's my preference for many patients. I do these operations mostly as a day stay. Patients go home the same day, often at Bay State Medical Center, and it's an in and out operation, pretty straightforward. The differences between silicone and saline implants are silicone tend to be lighter in weight, they ripple and wrinkle less. Unfortunately, they're a little bit more expensive. The downside about saline is they tend to ripple and wrinkle a little bit, and they're definitely heavier in weight, which can droop a little bit with time as well. The silicone implants we use now are considered the gummy bear. They're fully cohesive gel implants, also known as form stable implants, and that adds an additional safety profile because the gel itself is very thick, it's cohesive, it's almost like Jell-O. If you cut through one of those implants, bring it in two halves, it's not gooey or gooey, it's really almost a solid piece. And you can imagine how that would be much safer than a very liquid gel if you had a rupture or a deflation or a problem with the implant itself. The difference between saline and silicone, one of them is deflation. Saline implants, if you get a deflation, if you get a hole in it, then most likely what's going to happen is in the first day or two or three, the implant's going to go flat and your breast will go flat. Whereas with the silicone implant, if you get a rupture of the implant, all of these things are pretty uncommon, but if you get a rupture of the implant, then it's not going to be noted by the patient most of the time. It's a silent rupture because it stays contained within the capsule and it's semi-solid. I think that's good for most patients. The downside is that you don't know it, but there's not many dangers associated with it. The FDA recommends that we get an MRI starting at year 3 to look for silicone breast implant ruptures, and every 2 years thereafter. And I think that's a decision between the patient and the plastic surgeon as to how they follow that guideline. My incisions are usually inframammary, that means under the breast. Now occasionally I'll use an incision that's around the areola or into the armpit, but my preference is usually under the breast because it's the simplest, most direct incision. The downside of going under the armpit, from my perspective, is a little bit dirty of an area, and through the areola you can lose some feeling in the nipple, and it is, again, a little bit of a dirtier area. The implant dictates the size of the incision. So a bigger implant needs a slightly bigger incision. Usually the incision is about 2 inches long. A saline implant goes in empty and gets filled inside. So we can use a smaller incision for a saline implant than a silicone. Most of the time, I'm using a submuscular placement of the implant. What does that mean? I put it under the muscle. Now, how do I choose that? Well, submuscular augmentation allows us to hide the implant by the muscle, and you see less rippling and wrinkling. The downside is that sometimes if you move the muscle, you can get a little bit of movement of the implant. And that's something that most of us who consider ourselves experts in the field have reduced to really a minimum. And we call that animation. When you move your pec muscle and the implant moves a little bit. The only people that I really tend to put above the muscle, for sure, are women who are involved in fitness modeling, where they're flexing their pec muscles in front of people, and then I'd rather put it above the muscle. But again, some of that's a personal decision with the patient, how we choose that. Above the muscle is less painful, but below the muscle is pretty much the standard of care for most people. The other benefit of going below the muscle is one of the risks of this surgery is capsule contracture. Capsule contracture is soft, pliable, and a grade 1 capsule contracture is a normal, soft, saran wrap, clear, pliable scar around the implant. If you go below the muscle, the risk of getting any further scarring is less than going above the muscle, so I prefer below the muscle. Grade 2 capsule contracture is a little bit more firm, it's like wax paper. Grade 3 is very unusual. That's more firm, and sometimes the patients can actually have displacement of the implant. That occurs in about 2 to 4% of patients. So while it's uncommon in a busy practice like mine, we can see it occasionally, and then that might require additional surgery later on. That's one of the reasons for revision. Usually a malposition associated with a capsule contracture, meaning the implant moves because of the scarring, and we have to take out some of the scarring and replace the implant in better position. Again, that's 2 to 4% of patients, pretty uncommon. Other risks are pretty uncommon as well: infection, bleeding, a bad scar or asymmetry, need for revision surgery. The other thing that's very uncommon, but it's received some interest in the news recently, is ALCL, or anaplastic large cell lymphoma. This is a rare disease of the scar around the implant. 1 in 30,000 patients will get this. It's almost not worth mentioning it's so rare, except the media has brought attention to it, and thus we have to bring that to our patients as well. It's been associated with textured implants primarily, but again, a very rare, uncommon circumstance that's very easily treated in most cases. Post-operatively, I ask the patients to restrict their exercise completely for about 2 weeks, and then more vigorous exercise for 4 weeks. So running, things like that, 4 to 6 weeks in terms of jumping, horseback riding, things like that that might cause displacement or the implant bouncing around a little bit. We have to be particularly careful. We usually waterproof the dressing, so patients actually can be out and about and shower 2 days after surgery and feel pretty good. We put them in a garment after surgery that helps to give them some support, and if they're uncomfortable with that, we can switch to a tank top with a shelf bra as well. Other risks of the surgery that we didn't talk about: leak or rupture. We mentioned that earlier a little bit. Saline implants can deflate, silicone implants can rupture. When you look at the numbers, it's about 1% at 6 years, it's about 6% at 10 years. Most of the manufacturers have a warranty associated with those implants for 10 years associated with rupture, meaning you'll get paid to change the implant and a free implant. After 10 years, most of the time they'll give you a free implant for a rupture. So they have complete faith in the implants and how well they'll do over time. Other things that we talked about, like rippling, pretty uncommon, especially with silicone implants, especially with a fully cohesive gel implant, and seroma formation, which is fluid around the implant, which I don't see very often. I think it's a rare circumstance to see that as well. For many patients, I prefer a textured implant because it does decrease the risk of capsular contracture. Smooth implants still have a low incidence, and they're better sometimes for patients who have a little bit of a loose skin envelope because they do follow the breast a little bit more than a textured implant does. Most breast augmentation patients that I do, I use a round implant. There are shaped implants out there. There are some downsides to them. They can turn, and then the shape becomes a little bit abnormal, and they have a higher predisposition to actually maybe some fluid collections at times. So I don't use them necessarily in most patients. That's pretty much the basic information that you need to know about breast augmentation. I hope that leads you to some good decisions about what you might do and an interest in our practice and interest in going forward.